EEG machine. So, but anyway, we always know HRV that way. And the common things that regulates HRV would be exercise, weight loss, meditation, mindful prayers, slow breathing, mantra, excessive writing, cold water immersions for recovery, and even daily far infrared saunas. So this is to at least around two 2 weeks, I think. That's the study that shows that. But the one that surprised me with our lessons today, there are supplements that actually can improve HRV. So this will be fish oil. So the dose would be DHA, 260 milligrams, and then for EPA, 60 milligrams. So this is dose-related response. The higher you give yourself fish oil, such as when the studies range from 2 grams to 6 grams per day, this actually affects HRV better. Another supplement that affects HRV, St. John's wort of 900 milligrams per day, lavender, especially in aromatic oil form or even foot baths. So 200 microliters in capsule form. And the Japanese medicine called Kampo, it's a blend powdered of ginseng 250 milligrams, bezoar 50 milligrams, glycyrrhiza 50 milligrams. And also for the patients who are deficient in vitamin D and B12, if you correct that, HRV will also be corrected. Zinc also is a prenatal supplement that results in higher HRV, not for the mom, but for the baby. So that's an interesting one. And then GABA, again, the studies were actually in covered chocolate form, and this actually helps post-exercise HRV. So for food, you could also use salmon. So 3 meals weekly over 6 months was the study. It improves HRV, sleep, and anxiety. Yogurt with bioactive cultures and B vitamins, 1/2 cup twice daily. That also helps. Out of all the diets, the Mediterranean diet has a higher association for improvement of HRV. And when you also consume 500 mils of water in one shot, acutely improves HRV for healthy people. And then for wine, not beer or spirits, low, moderate daily consumption appears safe and beneficial. And lastly, surprisingly, coffee of 250 milligrams, usually 2 cups twice a day, improves HRV. So again, I just thought HRV is improved by all of these specific activities, but there are supplements and dietary interventions that you can actually involve in there. So that's my Andrew Weil tip of the week. Is Dr. Quinn here?
Yep.
Dr. Quinn, are you there?
Yes, yes, sir. I'm here. Can you
So
hear me?
yes, so for everybody, I definitely want to congratulate Dr. Quinn. We are thrilled to celebrate your deserved appointment to the Nevada State Board of Homeopathic Medical Examiners. Being selected by the
Thank you.
governor is a tremendous honor and one that reflects your exceptional dedication, integrity, and commitment to the people of Nevada. As a board
Amen.
member entrusted with safeguarding public health, your role is both a privilege and a responsibility. If you are chosen, I tell you, and your selection after rigorous screening is a testament to your expertise and that the trust placed in you. So we have no doubt you will serve with wisdom, vision, and unwavering dedication. Congratulations on this remarkable achievement.
Hoorah.
Thank you. Thank you very much. Now the work starts.
Right? So now
Right.
you're a public servant, not a senator
That's
yet or a
right.
governor, but
Yeah.
stepping stone.
Good. Yeah. Well, thank you. Thank you. I look forward to it. I look forward to working with you and the others as well.
Yes, of course. So, but yeah, it will be a great. Well, you probably have more years than us because we're already serving, and
Yeah.
yeah, but it'll be good.
Good.
We'll give you all the help you need.
Good. Thank you. Yeah. As a matter of fact, I have a call tonight with about 6:30 or so with Charles Green to kind of get the lowdown on what had been happening.
Okay, all right, good. Yeah, he's a good one. He did good work for the board.
Yeah. Also, I think John Glavinovich, Dr. Glavinovich is going to be on the call too.
Good. Yeah, you're in good company there.
Good, 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 good. Well, thank you very much. That's very nice of you to say. Kind words.
You're welcome. You're welcome. All right, Dr. Tano, are you ready?
Yeah.
All right, let's do it. The floor is yours.
So do you guys see my stuff? Yes.
Yes.
Decoded. Very good. So as you all know, I don't do any straight lecturing. I would appreciate all your participation possible to make it a success. Stefan, my man, I saw you earlier, so I think you're there.
Yes, I'm here.
Okay, good. So you're gonna help me.
Yes.
All right. So today we're going to talk about Cholesterol Decoded. And this is a book that I have actually put on Amazon. It got a little bit of traction. People are reading it. Last month, they read probably about 1,000 pages. And so it means that some people are interested in this topic. So if you take many of the chronic diseases that we have in America today, we have the hypertension, diabetes, cholesterol come next. So that's part of the things that all the doctors are treating. But I really think that we're not mastering that very well. So there are some parts that are still missing, and it would be nice for us to understand it very well, so then we can decode it and help other people understand it also. So Cholesterol Decoded, the good, the bad, and the misunderstood. So that's what the title is. And this is on the Mediverse, our TirePro Mediverse, in a digital book format. So those of you who are interested in reading it, you can. And also we have a little documentary that goes along with it. So both of them things that you can have access to if you want to. You let me know, we can just give you access to it, at least for now for this group. So trying to pass. Yeah. I think it's sticky. I'm going to minimize this one here. We're going to skip all of that. So the objectives, we're going to understand the historical significance of answer keys. So how many of you know the answer keys 7-country study? Because I think that actually changed the way we see cholesterol and fat in this country. Many of us know about answer keys. And who was he? Stefan, do you know?
Yes, I'm aware of Ansel Keys. He was a researcher that traveled to these blue zones back in the day, and he associated their dietary habits with their longevity. But his research was promoted over another researcher who studied the Eskimos in the Antarctic, found opposite readings regarding cholesterol, but for some reason his ideas were promoted over the Eskimo findings.
Right.
Yeah. Also, isn't he the guy that invented K rations?
K
For the
ration.
military? K rations for the military.
That's 100% right. That's
That
right.
is possible, yes. Yeah, so that's good. So answer keys, he was, what, do you guys know what he did as a profession? So this guy is very significant in modern history because he impacted the way America nourishes people overall. So it's nice to know a little bit what he did.
He cherry-picked data and then he promoted it to Congress and the American Heart Association, and then he got his concept of the lipid hypothesis promoted for the next century.
Correct. So based on this one study, the 7-country study, the whole dietary nutritional recommendation in America changed completely. And we followed him blindly, or I would say, I don't know, for several years. And now we know the result. The result is what we're witnessing in terms of metabolic syndromes and everything else. So Esakis, he was a physiologist in my home state of Minnesota. That's where he was from. And he was the one who came up with the studies, and we're going to talk a little bit about that. So describe a physiological function of cholesterol. So many people, when they think about cholesterol, we think of it as the bad stuff. We hear cholesterol, we all run away because we think it's going to cause heart attack. But without cholesterol, the human being cannot function because cholesterol has many, many useful functions in our body, the cells, everything else. And so it would be important to see what the cholesterol does. So we need to identify the types of subtypes of lipoproteins. And the lipoprotein or lipoprotein, as I call them, we have several of them, but we need to understand what they mean. We distinguish between normal LDL and oxidized LDL. I think that's where the confusion lies in terms of cholesterol, the oxidized LDL, and explain the mechanism of foam cell formation. The foam cells, we all know, macrophage that get engulfed with eating the cholesterol remnants, so they become obese and they create more trouble than we think. And then analyze the composition of the atherosclerotic plaques, interpret advanced lipid panel results, and explore the orthomolecular and functional medicine approaches, explain the role of insulin in the cholesterol biosynthesis. I don't think I went there, but we can talk about that. Connect insulin resistance and dyslipidemia. So many of you who have assisted or who have come to some of the presentation that I did, I came up with a macro medicine diagram, and I also have written now a book about the macro medicine ideas where we connect everything. So if I show you my macro medicine diagram, that is the house. Remember, this is the big house where we start from cholesterol being the foundation. So cholesterol is the starting material to build this whole big house. Many times when we say cholesterol is used to make the hormones, many are not quite clear which part of cholesterol is used to make the hormone. So I put it in here as the LDL cholesterol, so-called the bad cholesterol that is used to make the hormones. So our good hormones and many of the body functions depend on the LDL cholesterol. So what does LDL cholesterol do? What is the role of it? So how do we differentiate? Well, because we hear LDL, HDL, all of that. How do we differentiate between LDL and HDL cholesterol?
Doesn't it transfer the hormones via each other? So your little map right here showing you the pregnenolone, the progesterone, DHEA, testosterone, estriol, it transfers all that via the cholesterol transportation system, correct?
Yeah, so the LDL is like the packaged cholesterol from the liver. So because cholesterol is made in the liver, and when it's made there, it has to go to all the different places where it's needed. It can go to the gonads, it can go to the adrenals, it can go to every cell in the body. So how do we get the cholesterol to every cell in the body? Is the LDL cholesterol package that takes that cholesterol to the different parts of the body.
Wow. Good question.
So LDL is very, very important. Now, let's, for argument's sake, look at that LDL. We think that when we do the general cholesterol testing, we measure the HDL, the LDL, all of that. And if the LDL is very high, we say, well, you're going to die of heart attack. So we have to somehow reduce that LDL. And many times when the patient come and complain, we never really look at all these aspects, but it's very important to find out if they're on statin drugs and they're feeling weak, they have aches and pains, they cannot think straight, they're a little forgetful. Could be because they're reducing the LDL so much that they have nothing left for the body function that require the cholesterol. And that is very important that we become aware of it. And so the things that we'll talk about, like the lipoprotein fractionation test, is going to attest to that normally, if we fractionate the LDL, the HDL, and all of that, then we will know which part of this LDL is not good. So then we can tackle it or try to address it rather than looking at the whole LDL and say that this is the villain, we need to attack it. And I'm not sure why in the 21st century, because the test to do the lipoprotein fractionation test has been around. I was aware of it since probably 2010, 2009 area, but still the general practitioners have not caught up yet. If they order cholesterol, it's always the old total cholesterol, HDL, total LDL, and all of these things that they measure, and they're starting people on statin drugs based on those results, which I think is really malpractice if you look at it. Yeah. Any questions about these things so far?
Yeah, well, yeah, I've been ordering these lipid particle fractionation tests for a couple of years now. I've looked at probably maybe close to 500 plus or more.
Right.
And you know, this is some correlations you can find with the standard lipid panel. So the standard lipid panel is like maybe $2.50, and the advanced one is maybe $20. So it's great value. I think the best part of lipid particle fractionation is the insulin resistance score that you can get with it, with the NMR on LabCorp. And then you can also get the small LDL particle count, but then you can also get the total LDL particle count. And I've seen numbers very high sometimes where it's up to 2,000 and even 3,000. And when it gets up that high, I start them on pharmaceutical therapies. And whether that might be a simple ezetimibe or even in some cases, rosuvastatin, that seems to be my threshold when it starts getting upwards of, 1,800, 2,000 plus.
Right, when it's getting very high, yeah. So we will talk about that. I have all the information about that, so we can discuss how to read it and what needs to be done when those are high or not.
Good.
Other questions? So as you know, without LDL cholesterol, we have no good hormones. So our good hormones come from the LDL cholesterol, and it goes to pregnenolone. Pregnenolone goes to progesterone, DHEA. By the way, so where does this LDL go? Which organelle is receiving this LDL? Anybody? Where does the
liver, the liver.
I couldn't hear.
Liver.
No, the liver makes it, and then it's packaged in LDL, and LDL is going to go to the different cells. So which part of a cell is going to receive the LDL to make the magic happen? So for instance, this is going to be adrenals, but which part of the adrenals is going to receive it to do the job?
The intermitochondrial membrane?
In the mitochondria. So now, talking about the mitochondria, how many different parts of the mitochondria do we need to know that is important in the cholesterol metabolism? Anybody?
All of them.
All of them, but let's say two parts that are very important. So we have the outer membrane and we have the inner membrane. So where does the action take place? Where the mitochondria transform the cholesterol into subsequent products? Where does it occur?
Does it go from the outer membrane to the inner membrane, right? That's that trend.
From the outer membrane, exactly. It goes from the outer membrane to the inner membrane. So why do you think that cholesterol accumulates when we get older?
Lack of membrane permeability.
That's correct. Lack of membrane permeability, because of the outer membrane somehow when we get older thickens. And when it's too thick, then it's difficult for the cholesterol to go easily through the membrane into the inner membrane where the enzyme that transforms the cholesterol is located. So if that is the case, then what do we do? How many of you know what we do to try to facilitate the transfer of the cholesterol into the mitochondrium? What supplement? What
Yeah, through
supplement?
Phospholipids.
What supplement do we use to as a shadow for the cholesterol to be transported inside the mitochondrion?
Phospholipids, yeah.
Fats.
That's one way. And other supplements that we use, anybody?
Anti-factor.
Who said that?
Anti-factor.
Who said L-carnitine?
I did.
Okay, yeah. So acetyl L-carnitine is the shadow, and that's why that supplement is very important. So if you have patients who have high cholesterol and all of that, they should be on acetyl L-carnitine, because that would allow them to shadow the cholesterol into the mitochondria. That's one way. So when the cholesterol gets there, so how do we get vitamin D?
Does the sun convert the cholesterol in the skin to vitamin D?
Yeah, so in the skin, so the UV light will convert the 7-dehydrocholesterol into the vitamin D. So again, here seeing the function of cholesterol, LDL cholesterol, is not only to make our good hormones, but also it makes things like vitamin D. And the integrity of our membranes, the cell membranes, all of those are due to the cholesterol. So if we play games and start reducing this cholesterol in the body, well, chances are many things will go wrong, including...
Yeah, but why do the patients with obesity have also a low vitamin D and high lipids?
Yeah, so that's a really good question, because of I think the insulin resistance and all of these other things play a major role in that too. So I don't have an answer. Do you know, Stefan?
No, I have no idea, but I always see it.
Yeah, it's clear, because we have a lot of obese individuals who also have vitamin D deficiency.
Yeah.
But vitamin D deficiency in general may be due to the fact that they're not exposed to the sun. But in America, except for Florida, where everybody is naked, no, sorry. So
yeah, but it is not explained, because the low vitamin D level, we're talking like maybe in single digits or like 19 vitamin D hydroxy, and they have such obesity, it's not explained, because I don't see it in the general population that doesn't have the extreme obesity.
Well, yeah, true. Actually, it does though. For instance, if do you know the population that has the one of the lowest vitamin D in the whole world?
No.
Actually, in the tropics. I've seen so many people from the tropics, Africa, India, who have very low vitamin D. And I think it's because of a lack of exposure to the sun. The sun is so hot. Many people don't just go into the sun and bathe in the sun and do all of that. So they're not getting the vitamin D. At the end of the summer here, I measure a lot of vitamin D and it's always low. So people say, I'm getting my vitamin D from the sun, but they're not getting it. It's not working.
It's not, no, it's not that easy. We're at 4,500 to 5,000 feet here in Reno, Nevada. And Dr. Clearfield could talk about it, but we have a lot of people who are vitamin D deficient and they don't know why, because we're supposedly close to the sun, but it just doesn't seem to work. So it's not just sun.
Yeah, it's not just the sun, but my thinking is that we're not exposed enough, because when we go out, all that is exposing is the head, the face, the arms, because people are always wearing clothes.
Agreed.
And the sun is not penetrating those clothes and get us vitamin D. I
Right.
think, and plus we do use sunscreens, and that's one thing that they tell us to wear all the time. And so in the end, we don't get the vitamin D.
For the obesity part, vitamin D is fat soluble. So this actually devoids the systemic circulation of that vitamin D. So that's why when you test it, it doesn't show up because it's staying in the fatty tissue.
The fat cells, yeah.
Right. Right.
That's a good explanation, actually. Yes.
Yeah, it's kind of thought that if you want to get your vitamin D from the sun, basically the exposure is playing volleyball on the beach for 8 hours a day in Hawaii. That'll probably do it.
Right.
Right.
Correct. So definitely, so the cholesterol, LDL, converts to the pregnenolone and then all of that. So we know this mechanism. We know in terms of hormones, we definitely need a good LDL amount. Now, the LDL does not go by itself. So that LDL is combined with a protein. How many of you know that the name of that protein and what it means? So there's a protein part and there's a lipid part. So what is the protein part called?
Apolipoprotein.
It's the apolipoprotein. So what does apo means? Does anybody know what apo means? Because of the time, apolipoprotein, apo that, apo this, apo A, A1, apo A2, FCC, etc. But apo means what?
It's a carrier protein of the lipids.
It's a carrier protein, but what does it mean? What is it? Well, apo is a word. It's a Greek word, actually, and it means something. So apo means from or without. So that part apo means it's a without the lipid. So if you take the protein itself, that is part of the lipid component, the lipoprotein. The protein part that does not contain the lipid is the apo part. So the apoprotein means it's a part of the protein without the lipid. And that's why the apo means without in this case. So what apoprotein goes along with the LDL to be transported to the cells and get to the mitochondria and all of that? Anybody? So we have the ApoB100 that is going to be the transporter that will help the LDL go to all the places. And we'll see as we go and talk about that. So
Dr. Tano,
yes.
Does the protein that's not bound to the lipid do anything?
No, it's by itself. It doesn't really. It
just
goes to
floats
attach
around
to
and does nothing.
Yeah, it does. It can occupy the receptors, but it doesn't do anything. It has to be attached to the lipid to be able to do the transforming.
Can't do anything else. No other protein use.
Right.
Oh wow. Thank you.
And the history, the history of the apoproteins actually started back, long time ago. People tried to figure out in the 50s, 60s. That's when they were trying to study that apoprotein, that they came up with the numbering, apoprotein 1, apoprotein 2. They have the C's, they have all of the numbering of it. But I tried to figure out who actually named them. But I said it's a combination of everybody coming in with some determination what they should be called and how they should be numbering them. So they didn't give credit to one particular person who discovered it and did everything. So I can go forward because I want to just show you a little bit how this LDL cholesterol goes. Here I talk about small dense LDL particle. So the particle sizes, the LDL particles are very important, right? So if we take about the LDL cholesterol, which is the lipoprotein plus the lipid part by itself, it doesn't mean a whole lot, but the LDL particle means a whole lot. So the particle also has several different subclasses. So we have a total LDL particle. How many of you know how much that should be in our blood to say, well, that's okay? Offhand. I don't think that's a fair question, so let's go. Let's go forward and let me show you things. I'm just filling out all of this stuff. So as much as I can, I will give you nutritional supplements that intervene at different levels of this whole thing. So let's talk about answer keys and answer keys discovery. So the seven country studies started in the 1950s. It was a longitudinal study where they followed people over 25 years. And the countries that were involved are the following: United States, Italy, Greece, including the island of Crete. They have Yugoslavia. So who was the president of Yugoslavia? Anybody? That's a trivial question.
I'm going to guess Tito.
Tito, very sure, Tito, yeah. And the Netherlands, Finland, and Japan. Those were the countries that were included in his studies. Without any going further, how many of you could guess the countries that had the worst outcome in this study? Anybody?
United States.
United States, that's one of them.
Italy.
And one other country that is also part of it. I didn't hear.
Italy?
No,
Finland.
not Italy. Not Italy, no.
Not Italy, no, bro.
Any other country besides the United States that was...
It was Finland, probably from the vitamin D.
Finland was the one, because Finland, they were eating a lot of... do you know why Finland was included?
No.
What were they eating in Finland?
A lot of fatty fish.
A lot of fatty, not fish, but they were eating a lot of
Fried foods.
fatty foods, cheese and milk and stuff that they have. So that is why they were having problems that they have. So there were a lot of people who were included in this study, 12,000 people. And it's male, so there's some sort of discrimination here, but didn't include any women. They included the men, 40 to 59 years old. So already you can see that the study is biased somehow because the gender choice is not adequate. From both rural and urban areas in the country, follow-up for 25 years, and they wanted to know their dietary intake via surveys and food sampling. Physical activity, serum cholesterol levels, blood pressure, smoking habits, and incidence and mortality from coronary artery disease. Their findings were that population with a high saturated fat intake, Finland, US, had higher serum cholesterol levels and higher rates of heart disease. Population with low saturated fat intake, Japan, Crete, low serum cholesterol, low rates of heart disease. Mediterranean diet benefits. So that's when they talk about Mediterranean diet. Diets in Greece and Italy were rich in vegetables, fruit, legumes, olive oil, and fish. These diets were associated with low cardiovascular disease incidence despite moderate fat intake because the fats were mainly unsaturated. In Japan, very low fat intake, mostly from fish, and lowest rates of heart disease. Finland, high intake of dairy and saturated fat, highest rate of heart disease. Serum cholesterol as a predictor, strong predictor between average population cholesterol levels and heart disease mortality. So that's a conclusion right there, thinking that limited saturated fat intake, replace saturated fat with unsaturated fat, olive oil, or nuts and fish oil, adopt Mediterranean style diets. And so now we know why the Mediterranean diet is good and everybody is after it. increase physical activity, and avoid smoking, because they also looked at smoke as a contributing factor. Impact of the 7 countries, because of our foundation for the dietary guidelines, it influenced the US and global dietary recommendation, particularly the low-fat diet movement in the 1970s and 1980s. So question is, do you guys know when the skim milk, 2%, 1% milk in the United States came in on a larger scale? Because the farmers had always done it, but to bring it to the market and make it official, do you know when?
It was when Congress made this motion. I think it was in the 1950s, 1955.
Actually, 1974, that's when the FDA said that we should probably do bring in some the skim milk. So you can see that some of the things that we did back then were based on some of these studies that were not quite to par in terms of design. Controversy, critics argue Keys ignored other countries' data, overemphasized saturated fats, possibly overlooking the role of sugar, refined carbs, and other lifestyle factors. Modern perspective, while the role of saturated fat is still debated, the overall emphasis on whole foods, plant-based diets, and healthy fats remains widely accepted. So, question that I have for you guys is why now we're having saturated fat like coconut oil and grapeseed oil, avocados? Now we're having them in the market so much, and in terms of recommendation that these are good fats. Anybody?
I don't know. How did this come to be? Because we know it, but I don't know how it became mainstream.
Okay, so anybody knows why all of a sudden they say, oh, let's do avocado, let's do coconut oil, let's do all of that, and it becomes a big thing in the market?
Does it have to do with trans fats, removal of trans fats?
Yeah, true, but they could do other things. But they're not recommending vegetable oils such as peanut oil or canola oil and all of that, but they're recommending saturated fats such as coconut oil being good for us and stuff.
Because of the medium chain fatty acids.
The medium chain fatty acid, yes.
It's money based. Money based, right?
Well, so it's by observations, but the studies, I'm not quite sure who did the study, but there's something called the African paradox. So the Africans are observed at the time when people did this, they said, oh, fat is killing us, cholesterol is bad for us, and let's weed it out. We found out we did all of these and still people died of heart attack. The heart attack rate did not go down in developed countries, especially in the United States. And so people start questioning the validity of this diet or this fat that we're taking out of our diets. When people look at Africans, they found out they eat a lot of saturated fat, palm oil, coconut oil, they're eating all of that, and they did not have a heart attack. Back in the old days, for sure, they did not have a heart attack. So someone was thinking that these Africans are eating all this saturated fat and they're not getting heart attack. Why not? Then they decided to see, and they found out that when you eat the saturated fat like coconut oil and all, it actually makes your large particle LDL that we're going to talk about larger instead of a small dense particle that is detrimental to the coronary, that makes the coronary artery disease and all of that. So that's when they've decided maybe we should bring in all these good fat that the Africans are eating. Let's bring it in our food too. So then they brought the coconut oil, the avocados, and all of these fat that people are recommending these days. Modern perspective, we got that. So now, summary, you can see that United States high intake of red meat, dairy, and processed foods. Saturated fat intake was high, cholesterol levels high, heart disease mortality was high. Keynote of modern industrialized diet with a sedentary lifestyle causes heart problem. Finland also high dairy consumption, especially butter, very high saturated fat, very high cholesterol levels, highest heart disease mortality, and highest coronary artery disease mortality, diet rich in the saturated fat. And then Netherlands, they have, you can read it, high, and then they have similar to the US. If you go to other countries, Italy, Mediterranean diet, they have moderate risk and they have low mortality, then they're protected. If you look at Greece and Crete, same thing here, they have lowest mortality because of the Mediterranean diet. Yugoslavia, they were kind of moderate and very regional diet and moderate outcomes. And Japan, very low everywhere, and they have low cardiac risk. They eat a lot of rice. So that's why I eat a lot of rice myself too. But I didn't look at this, but I think rice is not bad as a carbohydrate. Depends on what type of rice you're eating. If you eat organic rice and wash it very well, perhaps it's okay, but there will be no arsenic in it. And vegetables, fish, very low fat intake. So overall summary is that out of all of these, the countries with the highest saturated fat intake leads to the highest coronary artery disease and mortality from heart attack. So conclusion is we should do saturated fat, we should do more olive oil, we should have fish. Now olive oil, if you look at it, are all olive oil created equal? Anybody? Anyone?
What was
Nope.
what was the question?
Are
No.
all olive oil created equal?
No,
They're not created equal, yes.
no. The first pass is usually the one with the highest antioxidant level.
Yeah, the first part is the green one. That's the one that is good.
Mhm.
But the time the olive oil transits through the ocean comes because they don't use it they don't send it by plane. They put on the ship and it comes all the way from Italy or other places to us. It's already rancid. It's already stale. So some people are arguing perhaps we should transport the olive oil really fast and bring it to us so then we can have the fresh olive oil that the Europeans and the Mediterraneans are eating that makes them healthy. So Dr. Gondry is one of them who is promoting this heavily. He goes to Morocco and he gets the olive oil from there and he's distributing that to his constituents. I think, you know, some of us will have to learn that and plug into this kind of distributorships. Japan and Crete had the lowest, etc. So you know the conclusion. So recommendation, etc. You know the end of that. That led to the food pyramids because not only that, they said we should eat the plant-based food, including the whole grains. So they change the food pyramid, they put whole grains at the base, and then we should eat more of that. So in the end, when we eat more carbohydrates, the more heart attack we had. So how does that work? How do we make cholesterol? What is the starting material to make cholesterol? Anybody?
Isn't it fat?
That's one. So fat is one of them. So how do you call the process of converting fat into cholesterol?
Acetyl-CoA, is it?
Yes. So acetyl-CoA is the product that is coming from the fatty acids. So how do you convert the fatty acids into acetyl-CoA? What mechanism does it? How do we call it? That's the basic biochemistry, by the way.
Boluses.
Beta oxidation.
Beta oxidation. So that's a beta oxidation. So by beta oxidation, we'll convert the fatty acids into the acetyl-CoA. Now, what other things go into acetyl-CoA? What else is converted into acetyl-CoA?
B5.
B5 is a cofactor, but what other ingredient goes into acetyl-CoA? And by what method? We know fat, we get the fatty acids that convert into acetyl-CoA via the beta oxidation. So why do you think diabetic patients have more cholesterol than anybody else? What is the mechanism?
Cellular resistance, they can't absorb the cholesterol.
No, but they have all the ingredients to make the cholesterol, right? So they have glucose, right? Glucose metabolism. So what is the glucose metabolism called?
Gluconeogenesis? Are you talking about?
Glycolysis.
Oh,
so
glycolysis.
we do the glycolysis. That glycolysis takes the glucose through all the glycolysis pathways and leads to acetyl-CoA. Then the acetyl-CoA can go through the Krebs cycle and give us ATP. That's one way. But that same acetyl-CoA is going to go into the cholesterol-making mechanism. And that's proteins also, some of them, they convert into acetyl-CoA. So we have the proteins, we have the fats, and we have the glucose that convert into acetyl-CoA, and that acetyl-CoA is going to go into cholesterol. So what is the rate-limiting enzyme for cholesterol making?
HMG-CoA reductase.
HMG-CoA. So the HMG-CoA is reductase is going to be the rate-limiting enzyme, HMG-CoA reductase. Now, what is the catalyst for that HMG-CoA reductase? What makes it produce more of the cholesterol for us?
CoQ10, I don't know.
Insulin. Insulin is the catalyst. So now you can see the diabetics, they have more glucose. Those diabetics, they have more insulin, the insulin resistance, many of them. Now, they have plenty of insulin then. That insulin is going to catalyze the HMG-CoA reductase, and that is going to convert the upline of acetyl-CoA comes down, and then that converts it directly into cholesterol. That's why the diabetics actually have more cholesterol than anybody else, because they have all the ingredients that is needed to make the cholesterol. So if we do the statin drugs, what do the statin drugs intervene?
HMG-CoA.
Yeah, the statin drugs are blocking the HMG-CoA reductase. So if they do that, then what is the consequence of that? What is the problem that may arise if we're blocking the rate-limiting enzyme? So then the cholesterol cannot be, or upline cannot go into cholesterol.
CoQ10 deficiency.
So that's one way. So CoQ10 deficiency, because the CoQ10 is made from one of the intermediates. And so when you have CoQ10 deficiency, what happens to the body then? What is the role of CoQ10, what it's going to do?
Mitochondrial problems, fatigue.
They're going to have mitochondrial problem, fatigue, pain, all kinds of stuff that they will get. But you will be hard-pressed that there are so many general practitioners who do give statin drugs without giving any CoQ10 to anybody. So what is the reduced form of CoQ10 called?
Ubiquinone.
Ubiquinone is the reduced form. So if you want to be more efficient, then you can give your patient the ubiquinol and then combine the CoQ10 with the ubiquinol, and then we get enough of that. So in essence, all of us, anyone over 40 should take CoQ10 to help in many ways. So the question remains, if I block the rate-limiting enzyme, which is the HMG-CoA reductase, then what happens to the cholesterol-making mechanism? Is blocked. So what else can happen to this individual who is taking the statin drug?
Cognitive decline.
They're not going to make a lot of cholesterol, but what will happen to them?
Yeah, cognitive decline, hormone deficiencies.
Hormone imbalances.
Yeah, they're going to have hormonal imbalance, they're going to have cognitive decline, but there's a major problem that will happen. So if they're diabetics, for instance, what will happen to their diabetes?
It gets worse.
It gets worse. The diabetes will get worse. Actually, probably 10 years ago or so, somebody wrote a paper in JAMA explaining that exactly, that women who take statin drugs actually be at risk of developing diabetes. So what my observation has been that many of the patients who are diabetics, who are taking statin drugs, they require several medications to control their blood sugar. They're not only on one anti-diabetic medication, they're on 3 or 4 medications, and that even is not doing it because they're blocking the glucose from going where it needs to go naturally, and that glucose is backing up, so they're having worse diabetes outcome. But that is not taken into account because nobody's studying this. They're just giving them the statin drugs, and they're not looking at what is happening to their blood glucose. They look at the end product, which is, okay, we did a great job with reducing the LDL cholesterol. It's really great. But then in the end, we have more diabetes.
Get every patient that's has a diabetic or even pre-diabetic, I get a letter from their insurance company, even though we don't take insurance, they should be on a statin.
Correct. Yes.
That's the standard.
Correct. But that's the standard of care. Yes.
The veterans community, same thing. That's what they do. That's all they do. They just put us on the statins.
That's correct. And that's because people don't realize all the harm they're doing to the patient. That's why I said some of these things is malpractice, because if you know the mechanism, the correct pathway through all this metabolism of glucose and fat goes through, and if you're doing certain things, you have to realize what your actions are doing in terms of a patient outcome. They're not looking at the patient.
They don't, I'll just be honest. The doctors don't have time. The doctors at the VA, they're absolutely overwhelmed. They see so many patients every day. So they're they can't follow up. They can't study this. They can't learn what we're learning right here. It's absolutely sad.
It is very sad, true. But all these papers, they make us go through all the hoops of maintenance of certification and all this nonsense, when a simple CME such as this may be able to help the doctor learn more and take better care of the patient. I was in an institution helping people, all the diabetics, they have 3 or 4 medications that they're using, and they're all on statin drugs. By the way, people are not satisfied using the low-dose statin drug. They give them the high dose. If you're diabetic, they give you 80 milligrams of Lipitor.
Right. Agree.
Which is not going to do anyone any good. So I think. So the function of cholesterol in the body, we talked briefly about that. Cell membrane integrity. Cholesterol is the essential structural component of the cell membrane. We know that. And it maintains the fluidity and the stability of the cell. Precursor to steroid hormone, we know that if we don't have that, then we cannot do anything. And it's a bile acid production. By the way, the cholesterol is made in the liver, and it goes to the gallbladder, and mixes with bile. Why does it do that? I think I have a result in front of you. So it mixes it with bile for better digestion of fat or absorption of the dietary supplements such as the fat-soluble vitamins. But what allows the formation of the bile acids? What in the bile plays a major role in producing the bile acids? Anybody? We call them bile salts. So the bile salts are key to making the bile acids that are used for absorption of fat in the body. Unfortunately, sometimes when the cholesterol gets to the bile salts are missing. So if there's no bile salts to allow the mixing of the cholesterol with bile, what happens? Anybody? So the cholesterol will precipitate, and it precipitates and forms stones. So that's how we get the gallstones. So if we have lack of bile salts and the cholesterol and bile cannot mix, then cholesterol precipitates and forms stones. And that leads to cholecystitis. So when we were in medical school, DO school, and all these places, and we learn about cholecystitis. The cholecystitis is whose problem? Who gets more cholecystitis in the population?
Women.
Female. What are the characteristics?
The fat 40.
The fat, the
female,
the fat
fertile,
further and 40.
The Fs.
Yeah, I call it before F. Female, fat, further, 40. So what is magical about that? Females, fat, further, 40. What is happening to these women? That is
hormones.
They have hormonal imbalance. If they have hormonal imbalance, what hormones actually are they losing when they're 40? So you can see that.
Better question is what don't they lose when they're perimenopause? I mean, they lose a lot of hormones.
They lose a lot of hormones. That what the key hormone that they're losing?
Progesterone.
They're losing the progesterone. They're losing the progesterone.
Yeah, because they become estrogen dominant.
They become estrogen dominant. So when they have estrogen dominance and they have low progesterone, the body feels like I need to make those hormones that they're lacking. And how do I make the hormones? We're going to increase the cholesterol, right? So we increase the cholesterol, and that part of that cholesterol goes to the bile. And because we have no bile salts around, then the cholesterol cannot convert into the bile acids. If it doesn't, then it precipitates and forms the stones, and the stones block the duct, the common bile duct, and then all of a sudden they have cholecystitis. So that's why. So back in school, we were learning cholecystitis is the problem of female fat further 40. We just memorized that mnemonic, but we never really questioned what is behind it. Why women? What is happening to the women that they're having this kind of situation? But that's clear what was happening and why they get that situation. Vitamin D synthesis, we talk about that. Brain and nervous system health. So the cholesterol is very important for the brain. So if we suppress it, then we're not getting a lot of brain function. That's why some people, by taking statin drugs, they become very foggy. They get foggy thinking. They cannot think straight. And so we have to take that into account. When people have Alzheimer's and all of that, we don't look at all the aspects of why they're having all these problems. We just say, oh, they're demented. But chances are they're doing something, or we're doing something to them that may be causing their dementia. Lipid transport, so it helps carry the lipids from place to place. Cellular signaling, So they affect the signaling of the cells. They affect the immune cells as well. So the immune function is going to be dependent on the cholesterol. Embryonic development, again, all of these are very important functions. So if we decrease the LDL cholesterol, then we blocking a lot of body function that are necessary for the well-being of the individuals. Structural component of lipoprotein, we have repair damaged tissues, so it does help with that, hormonal regulations, etc. So you can see all the rows of the cholesterol. What does it do? LDL cholesterol. So why cholesterol is important? Of course, I think we talked about that. And you can see in terms of the lipoprotein, we can talk about that. I've mentioned lipoproteins. We have the chylomicrons. So what are the chylomicrons? What do you know about chylomicrons? So it's here. So the chylomicrons, they are the intestinal lipids, and it's made mostly of triglycerides more than the cholesterol, and has the ApoB48. So the chylomicron is combined with the ApoB48. So if I were to quiz you on this, I would say, well, what is the apoprotein that goes along with the chylomicron? Then you would say the ApoB48. And what is the apoprotein that goes along with LDL cholesterol? Anybody? I said that before.
100.
ApoB100. So the ApoB100 is the one. And you can see for the very low density lipoprotein, it's made in the liver. And again, it's the ApoB100 that is the protein part. And then the IDL, the intermediate density lipoprotein, the ApoB100 again. And if we take the LDL cholesterol, it's ApoB100. The HDL cholesterol, as you can see, is the ApoA1 and A2. That is the transport protein. So it's good to know all of these things. I mean, that's what they grew us on in medical school, to know all this stuff, although they don't. So if you look at the sizes, it gives you the sizes. I'm not going to go into the semantic of that. But if you look at the video later, you do have all the information in front of you. Then you can, if you want to go nitty-gritty in detail, you can get all the details. Function of the triglycerides, all of these things, I'm not going to go through that tissue, targets, adipose tissue, etc. You can go through that. The chylomicrons, what they do, it tells you exactly what they're doing. It tells you each one of the LDL intermediate, you can see, and the HDL, you can see what their functions are. Importance of understanding lipoprotein function, cardiovascular risk. And we know the high LDL and low HDL will lead to cardiovascular disease. Metabolic health. So therapeutic targets, statin, the PCSK9. What the PCSK9s are? How many of you know what they are? Anybody? Does any one of you know a medication called Repatha?
Yes, it's the receptor, it's the recycling of LDL in the liver.
Yeah, so Repatha. So what is Repatha? Do you know?
It's a PCSK9 inhibitor.
Yeah, it is a PCSK9, but what is the nature of that medication?
The recycling of the LDL receptor on the surface of the cell.
Is a small gun or is it a big gun? Is it a BB gun or is it a big gun?
Big gun.
Just the price of it, it's probably a big gun.
It's a big gun, yes. Repatha is actually a monoclonal antibody. And so every field that we have, they're having their own monoclonal antibodies. And cholesterol has at least 3 or 4, I think 2 of them that are popular, monoclonal antibodies. And that monoclonal antibody, one of them is Repatha, which is the PCSK9 inhibitor. So for me, if we can figure out a different way of reducing the cholesterol, why use a machine gun instead of using BB guns to do the job? That's my analogy. And allergy and immunology will do that too. We have so many drugs, monoclonal antibodies. We have the Dupixent, the Xolair, all of those guys that we're bringing in to treat things that we can, like hives, or people have eczema. We're using these big guns in treating the patient with that, and they're very expensive. Then we say, well, the healthcare is expensive, but one shot is $1,000. So how many years can we put a person on that? That, believe it or not, there are patients who have been on these injections for years, 3, 4, 5 years, 10 years, they've been doing this injection, $1,000 a pop. So you can imagine how much cost the insurance is going to incur and distribute that on all of us in many ways. So for me, maybe we should think a different way rather than bringing in the healthcare, all these expensive drugs that are not going to change basically anything at all, because they're not really targeting the underlying condition. And that's why we who do functional medicine, integrated medicine, we have our place in this whole place to help the patient so they don't go this path. So they're not looking at root cause, they're not looking at anything, they just, you come, you have a problem, you have a cholesterol problem, okay. We give you, and we're not fractionating your cholesterol, we give you a statin drug, or we give you a PCSK9 inhibitor. You have a fibrates and niacin. So niacin, anybody can tell me what are the usage of niacin, vitamin B3?
It can help improve NAD levels. It lowers triglycerides.
Yes.
It can improve HDL. It gives you a good pump in the gym. It improves blood flow.
Right.
And causes vasodilation.
That's good. So niacin actually does a whole lot. So there was a Canadian psychiatrist, Dr. Abraham Hoffer, who did a lot of studies on people with mental issues, psychosis, depression, anxiety, bipolar, name it. And he gave them a high dose niacin with high dose vitamin C. And what is high dose vitamin C? How many of you know how much Linus Pauling was taking in terms of vitamin C?
30 grams.
That's a lot. He was taking a lot, but not that much.
Yeah, 30 grams.
He was taking 30 grams. I think he was taking 15 grams or so. But so I always joke that if he takes 15 grams or 30 grams, maybe, and he got 2 Nobel Prizes, maybe if I take 5,000, I would do a little better.
Yeah.
Right? So that's why I take vitamin C every day myself. I take probably 5,000 a day. But if you combine the vitamin C with the niacin, you get a better result for many of the depression, anxiety, and everything else, according to Dr. Abraham Hoffer. And his studies, he published them. He has a book on Amazon. For those of you who are interested in mental health, I think that would be a good reference. Very, very nice. So niacin is a big, some of the conditions that we're going to talk about require niacin. Absolutely, because if you don't have niacin, you may not use statin to treat those conditions, especially if you have a familial kind of hypercholesterolemia due to the lipoprotein A, LPA. If you have LPA, yes.
No, I'm sorry. Sorry to interrupt, Dr. Tano. 2 questions. Dosing on the niacin daily, 100 milligrams?
Yeah, so the niacin is 650 milligrams, but you have to double it up. So it would be probably anywhere 1,200, 1,500 milligrams a day to say that you're doing a good job.
And then when combined with the ascorbic acid, does that affect triglyceride levels?
Yeah, you should, because the niacin alone will affect not the triglyceride, but it affects the LPA, so the lipoprotein A, which is one of the genetic markers. So it's familiar. So some people have that, and if you have that, statin drugs will not touch that. So niacin would be the one that would take care of it.
That just seems really high dose of the niacin. It's got to be non-flush or something, right? Otherwise.
Well, yeah, but non-flush. So they do the non-flush. For instance, there are companies that I know, I'm not going to name them now, but the company that do the non-flush niacin.
And I think it was Dr. Hopper, if I remember correctly.
Yeah, Abraham Hopper.
With alcoholism, they started to tackle the alcoholism with these supplements. And Bill, the main whatever for Alcoholics Anonymous, he created a board full of doctors, and he finally came to the board about the supplements, and the board said no because they were quote unquote doctors. And what they found out is the niacin and the vitamin C was absolutely helping the alcoholics, overcome what they were going through. And Big Pharma kind of they just stepped in the way.
Correct. Yeah. As usual, as always, right?
Right.
When something is simple and natural and it's working, we don't want that. Let's just cut it out. Let's create big guns. Let's create PCS K9.
Agree.
So,
were there recent studies suggesting some problems with too much niacin, and they were talking around 500 milligrams. I don't remember what the problem was, but there was some recent papers talking about being careful with niacin.
I didn't see
the flushing, right?
The flushing.
No, it's not the flushing. That's not a problem. There was some problem to actually cut the dose down. Flushing is not a serious problem.
Got you.
Yeah, I'm not sure. So Mr. McCarran, who sometimes attends this meeting, he has a supplement line for chronic kidney failure that he uses niacin to treat. And he has all kinds of studies proving that the niacin actually helps revert the chronic kidney disease. I think that we should look into it, because for those of you who have patients who are having kidney failure, may be a good way to help them out. And I think Mr. McCarran would be more than delighted to help you with some of this information that he has that he's using.
Sure.
All the APOs, so I give you all the information about the APO proteins. Here I'm not going to go into detail, but there's a lot of them. It's not just APO B and A1 and all that. We have many, many more, and they have the genetic, what they're located on, the gene, the chromosome, the number, everything is given to you. So you can have access to it and you can go through it step by step. Summary of lipoprotein functions and genetic impact. They help with dyslipidemia, the atherosclerosis, the neurodegenerative disease, the autoimmune conditions. They create all kinds of things they're lacking. Alzheimer's. So what is the apoprotein that is involved in Alzheimer's? Anybody?
ApoE.
ApoE what?
4.
ApoE4. So the ApoE4 here, allele, can lead to Alzheimer's risk. So if we have that, and we can measure that differently, it would help people. If we have someone who is having Alzheimer's problems, we can test that and see where he is with that. Cholesterol-based measures. So we do have, when we do the lipoprotein fractionation test, we get all these measurements, the LDLC, and then we have the different classes and all of that, subclasses, but they don't give us these subclasses in the test. Total number L particle that I was telling you about, if it's too high, it carries a cardiac risk. HDL particles, if they're low, they carry a cardiac risk. So you want this one to be high, you want this one to be low, and intermediate one also carry a cardiac risk. So the particle size matters. Apoprotein meaning the B's, or you can go through this. I'm not going to go into the detail because I want to get to so the lipoprotein A that I was telling you about, the one that niacin will do good by, is this one. And that genetically determined LDL-like particle with prothrombotic properties. High levels, more than 50 milligram per deciliter or 125 nanomole per liter, carries a very high cardiac risk and stroke. So if someone has genetic marker for this, you want to be aggressive, and the treatment is niacin, because statin and all these other things will not touch it. Clinical consequence of homocystinemia. So homocysteine, oxidized LDL. So how do we get oxidized LDL? Let's talk about that quick. Anybody? So we have go ahead.
Eating the fried oils, the seed oils, I think that drives some of it.
Yeah, so we have the reactive oxygen species like superoxides, and those can combine with the LDL and then oxidize it through the apoprotein. So, or we can have a lipid peroxidation, and that also can oxidize the LDL. Once the LDL is oxidized, how does that cause damage? How does the oxidized LDL cause damage? Can it do it by itself, or does it need any help?
I think it's inflammatory.
Yeah, so it is inflammatory, but by itself, it doesn't do a whole lot. So in order for the oxidized LDL to do something damage, we have to have homocysteine around. So what is a homocysteine?
It's a secondary risk factor for heart disease, stroke, and dementia.
True, but what is it?
That's what you're asking.
So
it's a byproduct. It's a poor methylation, is what it is.
It's a byproduct of metabolism, and it's an amino acid. So that homocysteine, what does it do to our arteries?
Damages them.
So it circulates and goes to poke holes in the arteries. So when it poke holes in the walls, then the oxidized LDL, what we call the small dense particle LDL, cannot pass those holes. They lodges in and form inflammation. And when we have that inflammation, anytime we have an inflammation in the body, who is going to be the fireman?
Your LDL.
What are the firemen that came in to try to extinguish the fire?
Cholesterol.
No. What are the firemen? So we have the inflammation. Somebody comes in there to try to extinguish it. And who is that?
Fish oil.
Oh, you guys are going the wrong way.
Fish oil.
Well, fish oil helps. Yeah, fish oil helps with the inflammation, true. But
macrophages.
There are some macrophage, right? Yes. So monocytes are going to come in the area and they become macrophage, right? The monocytes migrate from the blood and they go to the area of damage and they become the macrophage. So those macrophages are going to eat the cholesterol remnants, right? They're going to eat those oxidized LDL that is lodged into the holes that the homocysteine has created. So they eat so much of these cholesterol remnants, they become obese. And they wallow there, they cannot move anymore, they die. So that forms more inflammation. So other macrophages come in to try to clean it up, and they're forming more inflammation. So as time goes by, we're getting a cemetery of these white blood cells. And that cemetery of the white blood cells, the macrophage, is what we call plaque. So that plaque, when it forms, it can obstruct the vessel lumen. And if blood is not going to the heart, then we get a heart attack. And if the blood is not going to the brain, then we get the stroke. So that's how these things happen. So it's important then to know that we should not have a high homocysteine level. Now, people who do tests, the general practitioners who do the cholesterol test and the general cholesterol, hardly ever they test the homocysteine. Very rarely you will see someone test for homocysteine, but it's a very key part of the cholesterol test, because if we have cholesterol LDL by itself, it doesn't do a whole lot. It can cause inflammation, but if we have homocysteine around, we need to know that that homocysteine is doing damage, and if it's high, that's when it does that. So what causes homocysteine to be high? Anybody?
MTHFR mutation.
If you have MTHFR mutation, so when you get the mutation, what happens?
You will have low folate.
You will have low folate and low
B6 and
B12, low
B12.
folate and B12. So if you have the mutation of the MTHFR, then your folic acid is not going to be methylated. You're not going to get the B12. And if you don't have those, then the homocysteine is going to go up. So there's a relationship between these three. And when homocysteine goes up and we're having all these problems, what do we give if we have MTHFR mutation? What do we give the patient to make things better?
You give them a higher dose methylfolate.
We give them high dose methylfolate and high dose
trimethylglycine and B12, methylated B12.
And methylcobalamin. So we're going to give them methylcobalamin. Now, do we have any methylcobalamin injection?
Yeah. Yes, we do. Yes.
No, we don't have that. No. So currently the B12 injection that we have is cyanocobalamin.
No. I can get methylcobalamin.
I've never seen that.
Oh, I can get it for you.
Okay, where do you get it from? Well, you will let me know. Okay.
Yeah, many pharmacies, yeah.
Well, I haven't, they make it. You don't buy just the general one.
Yeah.
Okay, so if they make it like compounded, that's possible. But I know why it's you don't find that. So it's a very important to check if somebody is having problems and having cholesterol is high. It would be nice to check the MTHFR mutation, and it's a test that many companies offer now. So you do the MTHFR mutation. If they have a mutation, then you give them. But luckily, though, currently all the professional supplement companies, they're offering the methylated B vitamin and the methylated folic acid.
Mm-hmm.
So they're not doing the regular one as before.
You also want to give them the methylidone or trimethylglycine.
Yeah, you give them trimethylglycine. So what is the other name for trimethylglycine?
Betaine anhydrous.
Betaine. So you do betaine, you can give them that trimethylglycine. So there is actually a digestive enzyme that contains betaine and HCl. Maybe some of you use it for people who are having irritable bowel syndrome and they're having all these problems. You can give them the
betaine hydrochloride.
Yeah, betaine
hydrochloride.
Yes, we give them the betaine HCl, but you give them also the digestive enzymes with the betaine.
Betaine hydrochloride.
Yes, we got you. So this is a sample of the lipoprotein fractionation test report and interpretation. So when you order this test, and luckily though, many of the important labs in the US do this test. So everybody has access to it. Maybe we should run a campaign for the general practitioners to do this test, because it's important for them to know the difference between the general cholesterol test and the lipoprotein fractionation test. I always try to educate the patient that I see to go to their primary care physician and ask them to do the lipoprotein fractionation test before they put them on statin drugs or any of the crazy drugs that they do. So this gives you the markers, LDL cholesterol. Now the dose, they say that should be less than 100. So this patient, 95 milligram per deciliter is normal. But let's look at his LDL particles. And Stefan will say that an LDL particle of 1600 normally should be less than 1,000 nanomole per liter. That is considered high particle number. And when you see that, it carries a risk, cardiac risk. Now you have a small density, the small dense lipoprotein, the small dense LDL. And that small dense LDL, when you eat carbohydrates and other things, the trans fats and all the other foods that we have, a processed food, then you make more of this small dense LDL. When you make that, it's a 45 milligram, that's a kind of high. It should be less than 35, and that also has a cardiac risk. And that's the one that actually goes into the holes that homocysteine is creating, and that's what the macrophage come in and eat and cause the plaque. On the HDL side, you have a total HDL cholesterol, 42 milligram. It should be the minimum, but you can do higher. You have to be higher than 50. That would be nice. So if it's greater than 50, it's a low protective HDL. HDL particle, if the particle is small.
Can we get these people to be muted here?
Yeah, if the particle is small, then it has borderline low HDL particle count. ApoB, we talked about that. That number, if it's 115 milligram, less than 90, it has a high elevated atherogenic particle. So if ApoA1, which is combined with the HDL, is 120 milligram deciliter, it should be greater than 130, that is slightly low. ApoB, ApoA1 ratio, like we do the LDL, HDL cholesterol ratio, but do that also for the protein carriers. And that ratio is 0.96. It's a high. Ideally, it should be less than 0.8. So for this patient, we do have a lot of markers that predisposes the patient to cardiac risk. So high ratio, high risk. LPA, the lipoprotein A that we talk about, 140, that is high. It should be less than 75 nanomole per liter. And that is very high cardiac risk. If we see that, definitely we have to give them triple dose of niacin and the stuff and try to help them out quick. LDL size, small protein B, pattern A, etc. So you can see atherogenic particle types. So this is one patient who has these numbers. So for this patient with the 1600 nanomole per L, which is less, should be less than 1,000, what are we going to do for him or her? Anybody?
Lifestyle changes.
I think Dr. Patel, somebody say, let's give him fish oil.
Not gonna do much.
But that will not do much now. So if we have that, maybe.
Methyl B12.
I didn't hear.
Methyl B12.
How about fiber?
or give them fiber, so you can go the fibrate line, give them stuff. But what else? So what is making this particle problem? So what should we do to tackle the underlying problem? That's why I talked to you about glycolysis and all of these other things. So if these people have this type of particle size, it means they're probably been doing a lot of carbohydrates, they're obese, they have that. So we have to clean it up. So how do we clean it up?
Biosalts.
Yeah, we can do that. I really think we should maybe look at the diet and recommend maybe the Mediterranean diet, right? That's one
But
way.
you were talking earlier about how to get these fats intracellular. Like, how do we do that?
Which one?
The fats, the LDL particle, how do we get this intracellular? Because I have been running this panel on children, pediatrics. I never see them have high LDL particle count, pretty much to a rule. I've had one, and they was very obese. But most children will have very low LDL particle counts. We're talking like 400 or 500. It seems to be, you said, a problem with age. So how do we bring back that youthful LDL pattern again?
Yeah, so you have to use all the armamentarium that we have. You have to give them cereal carnitine. You have to give them all of those things that will help in the cholesterol metabolism. You have to give them alpha lipoic acid. You have to give them all these nutritional supplements that can help the glucose metabolism. So if you did that, also correct their gut. You have to give them probiotic, prebiotic, digestive enzyme. Make sure the gut is functioning very well so then they can absorb the nutrients better. All of these things are part of it. And also, you have to limit the carbohydrate intake. Now, one of the things that we didn't see here is triglycerides. The triglycerides, recently they did an article that showed that actually that carries a high cardiac risk, which makes sense. So if somebody is eating a lot of, how do we know they have, what causes the high triglycerides in most cases?
Carbohydrates, sugar.
Carbohydrate. They're eating a lot of carbohydrate. They have sugar intake, high sugar intake, and that is leading to the high triglycerides. So it's important to control the sugar intake, the carbohydrate intake, limit that, and that would help them tremendously. So if we see this type of particle size, we have to go deeper, give them nutritional supplements, clean their diet, even detoxify them, clean them out, because sometimes they cannot metabolize because they're full of toxins. Clean them out, and then we look at all the aspects, check their hormones, fix their hormones.
Okay, we need to mute some people here. Can we have some active co-hosts here mute these people?
It's good.
Thanks.
Yeah. So we have to do all of these things to get this patient better, because we cannot just give them statins and all of that and expect them to do well. We have to go deeper, but sometimes the problem is the patient themselves because they don't want to change. Some of these patients, they have been eating the same diet for 200 years. And you tell them, hey, don't do bread. They say, well, who are you? I cannot survive without bread. I'm going to eat my bread. I will pray for it and I eat it. So that's what happens to many of these patients. So it's important to at least work with them and help them out, reduce, give them a good Mediterranean diet and some other diet. I have a Prophet Daniel's diet that I study everybody on. Do you guys know what the Prophet Daniel diet is?
I didn't catch that diet. What was it called?
The Prophet Daniel's diet.
Never heard of it.
Yeah, that's the thing that I created, Prophet Daniel's diet. So if you look at the Bible, Daniel chapter 1 through probably end of chapter 1, where Daniel and his companions were recruited by Nebuchadnezzar to serve in his palace. So Daniel and his 3 companions, he pleaded, but well, first of all, they were supposed to eat the king's diet. And you can imagine what the king's diet was. a lot of carbohydrate, the goodies, the cookies, and the cakes, and everything else, and wine, things that they're going to eat. And Daniel said, no, 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 we don't want the king's diet. Please give us vegetable and water. So vegetable and water. The chief eunuch said, hey, do you want the king to kill me? He said to give you his diet. And Daniel pleaded behind the doors. The assistant eunuch said, okay, Daniel, you got your wish. I'm going to give you 1 month. If you don't do well, you eat the king's diet. So he started giving them vegetable and water. At the end of the month, actually, Daniel and his companions were the most fit. They have more muscle, they have more intellect than all the other people who ate the king's diet. I call that the first clinical trial. King's diet versus vegetable and water. So it's important to eat the vegetable and water. Initially, if you have patients, you can try them and say, hey, eat a lot of vegetable and water, cruciferous vegetables, plenty. Can mix it with a little protein here, and then they can lose the weight. That gives them confidence to go forward with their weight loss. And that has been successful for some of my patients, where I put them on the Prophet Daniel's diet. I think we have gone far. Many of these things, so functional medicine approaches, we can give them low glycemic, like I said, low glycemic diet, anti-inflammatory diet. So if you want to give them potatoes, what potatoes you give them?
Sweet potatoes.
If they love potatoes, we give them sweet potatoes. And which sweet potato would be the best?
African.
That's a good one. Well, there's African yams. How many of you know the African yam?
You told us that when we were talking about vegetables more than cholesterol.
Yeah, the African yams, you can use that because the African yam, the giant, have you guys, if you don't know, go to Google, put in African yam. It's a big giant yam. That's where we get progesterone from, by the way. So if you see the Ghana yams, it's you fry it, it's a little bitter, just like progesterone. So when we do the progesterone extract, we call it wild yam extract. Those African yams can give you the progesterone. So in essence, if you eat the African yam that has low glycemic index, actually you can lose weight. So I put some people on the African yam diet. If in Africa, I tell them, hey, go buy yourself a lot of yams, eat them every day, and see how you do. And vegetables, plenty of vegetables. What about here? In terms of sweet potatoes, what is the best sweet potatoes? Maybe some of you should try it. The best sweet potato that I found is the Japanese sweet potatoes. That Japanese sweet potato is the purple one, purple skin, and it's a white inside. You fry them, bake them, man, they taste so good. So these are things that people can do. Eliminate trans fats and refined carbs. We'll talk about that. Omega-3, so we'll give them some fish oil. Increase fiber. They put flaxseed here. I don't like that because flaxseed on my list, my bad list, is estrogenic. And so I tend to do the estrogen-free lifestyle, and the estrogen-free lifestyle excludes the flaxseed. Psyllium husk, you can do that, that's fine. And plant steroids and stanos, you can do all of those. They will help in this patient. Supplements that we need, remember the niacin, I said we can do anywhere up to 1,500 if you want high dose. So you can do the high dose niacin, that would be good. And the omega-3, 2 to 4 grams a day. Berberine, you can do that. And then curcumin, which is anti-inflammatory, you can do that as well. And magnesium and CoQ10 that we talked about. So magnesium is very important because in the US, magnesium deficiency is a big problem. So supplementing everybody, for me, people come to my clinic, I give them some magnesium. I give them 2 sorts of magnesium. If they're having constipation, I give them magnesium and vitamin C, buffered ascorbic acid. It helps them tremendously, and they go. They don't need a lot of medication, Miralax, and everything else that we give them. So those are the major things that we're going to talk about. So I think in the interest of time, I'm going to stop here. Anybody has questions, I can try to answer those questions, and then we'll go from there. But you have the rest of the presentation. I think I put it all together, a lot of information that you can glean from here, and that will help you at least understand all the cholesterol problem that we have in this country.
You know, I'm going to start using this acetyl-CoA, or acetylcarnitine, you said.
Yes,
What's the dose?
acetyl-L-carnitine, yes.
The dose you take for this?
It's 500 milligrams.
Okay, I'm going to start doing that because I need something that can help shuttle the lipids into the cells. I think this is something that we need to try to do.
We all need to do that. So
I have a question.
I personally
about
take
that.
Yes, go ahead.
That I was recommended to do that, and then I started reading all this stuff about people. You know how statistics are; they can be made to say anything. But they said that they found that the people who were taking that 500 milligrams of that were having more problems and dying. The death rate was up. What people were saying, is that a bunch of baloney or
Which one? Which
the carnitine, the A-carnitine.
I've never heard anything like that. I never heard anything
okay. It's probably just one of those internet things that, is wrong. But I kept reading it over and over.
And also the sources matter though. So for me, if you get it from a reputable company, that may be better than getting from Walmart.
No, I was getting it from a good company, very good company. I can't remember the name, but it's a big name and it's a good company. But I just chickened out. So basically, and you didn't mention cinnamon for getting rid of
cinnamon extract, not cinnamon itself, right?
Oh, I'm doing quarter teaspoon, have been for years. My triglycerides. Mwah. And I told some woman that was asking me because hers were high. In a month, hers came down with just a quarter teaspoon a day. I throw it in my my smoothies. So it's really
okay.
Dr.
So
Tano?
I personally recommend the cinnamon extract for glycemic control. It works well. It's good. Yes.
I didn't hear you discuss tocotrienols for preventing the oxidation of LDL.
Yeah, that's a good idea. Yeah. So you do the vitamin E, the tocopherols, and so there are some companies that give you everything. They give you the 3 forms of vitamin E, and those are the ones that are better. I really don't think that it would be good to take only one form. So there's a company out there.
The tocotrienols should be taken by themselves, not mixed with tocopherols.
Okay,
but it will help prevent the oxidation of LDL. And is that the bad issue with the LDL? Is it still bad even if it's not oxidized? Or is it when it becomes oxidized, that's when it becomes a problem?
The oxidation is the problem. If it's not oxidized, it's great. So if you can prevent it from oxidation like tocotriene, you can do fine with it. No problem.
Okay, thank you.
Sure.
Just to add to that, one of the better ones also is the gamma delta type of tocotrienols to use.
Yes.
Right.
So that's more cardiovascular protective. And to answer the question about carnitine and cardiovascular problems, the one that I know about is the interaction or the conversion of this one to TMAO, because carnitine actually is metabolized by your gut bacteria into trimethylamine, which is then now transported to the liver to form TMAO, which is basically, again, cardiovascular irritant. So that's the only one that I can hear that you should check before going into high-dose carnitine. And to classify carnitines, acetyl L-carnitine is one that's better for neurological problems, and plain L-carnitine is the one for the non-neurological functions.
Yeah. Great, thank you. That's definitely I take the acetyl-L-carnitine for myself, because I don't want to create any problem where there's none.
So, Dr. Tano, there's some. Oh, go ahead.
I was gonna, if you let me share my screen, I'll show you the trend of my labs over the past year and how I use the forbidden fruit to lower my lipids.
So do you want me to stop
is.
sharing? Yeah, okay, good.
I'll show you. Okay, so here's my lipids. They've been very high. My LDL particle was like 1624. This was back in 2023. It was still high, about 2000, very high. I checked it with different labs like Vibrant, and it was like still very high. So I used the forbidden fruit of growth hormone, human growth hormone, 3 units, and I ran it for about 8 months. And this was the lowest number I've ever been able to achieve doing this. I got my LDLP down to 1200. My triglycerides always have been good, and you see my physique. I'm very lean. I'm an athletic individual. I eat a very good diet.
Right. Do you have any familiar one like your LPA? How's your LPA level?
Always negative. All my family members, my LPA is always negative. All my family members and myself.
Yeah. All right.
And my insulin resistance got worse on the growth hormone. I went up to 42. Typically, I'm always less than 25. My fasting insulin is like 2 or 3. It actually went up to like 7 on the growth hormone. So my lipids got better. My insulin resistance got worse. And what do you think of that?
So I think that's one of the effect of growth hormones. It's actually one of the chronic complications of that is the formation of diabetes because it actually worsens insulin and sensitivity. I think could that be because you're using low doses of it? Could that
Oh
be
no,
something
3
that's
units
happening?
is 1 milligram. It's not really a low dose.
But yeah, if you look at it, I have a lot of patients who are on growth hormone. This has issues with glucose metabolism eventually.
So what I was trying to make, my theory is like, can we reverse us to a younger level? Well, because the children's, their lipids are so low. I'm telling you, LDL particle of like 300, 400, 500, super high growth hormone levels. So I think it has something to do with their youthful hormones. I mean,
Right.
testosterone levels are very good always.
So have you tried L-arginine by itself and citrulline together instead of just the growth hormone that you're doing?
Well, yes, I used those in the past as nitric oxide precursors for the pump in the gym.
Okay.
I noticed in the presentation of the NMR lipo profile, it is not age specific. So it's just a one specific chart, which I think in the future they should probably do an age specific classification for that. I mean, that's just me. I'm using it all the time. There's just no differentiation.
Right. Yeah, because these people, I don't know who the advisors are, and I don't know who is guiding them. But many of them come up with this test and they start doing it and it works. They get people to do it and they're not actually improving on it. That's my feeling. So it may be good for people to suggest to them that this is what we're finding, and maybe you can change your test composition and make it better. As time goes by, nothing stays static. Things move forward, and we should probably improve on some of the tests that we have, but we don't do that. For instance, when we do the estrogen metabolites through urine, I have found out that that is quite inaccurate. However, that's what people stick by. When we were doing the blood test by some other companies, it gave us a better result. And now they made it disappear because the competition is doing the urine test, and they went to the urine test instead of continuing the blood test that was more accurate. So the labs, they just follow, they follow whoever is making more money or whatever, who is getting more press, and they go that direction. And it doesn't mean it's important, it's good for the patients. I think I've been fighting to try to get the estrogen metabolized by blood, but nobody's listening to me. I have no power. So I guess
when the lipids are very high, do you like ezetimibe?
Yeah, that works. It's okay.
Yeah, low side effect profile I found.
Yeah, there's a low side effect, so you can do that.
Yeah. I'll do that. I've done red yeast rice as well, and it does work to some degree.
But remember, if your LDL is you don't have, if you look at your particle size alone, it may not be sufficient. You have to look at your small dense particle. So how much is your small dense particle?
I mean, it wasn't. I mean, one
So
time it
because if your small dense particle is good, then maybe you don't have to worry much about the whole particle size. Because the small dense particle is the one that is atherogenic, that causes trouble.
I mean, yeah, but when I'm pushing an LDLP of 2000, I do get concerned, like
Yeah, yeah,
69.
that's high. But how much is out of that is your small dense particle?
One time it was quite high. It was 642.
Right.
And
Now it
other
went
times,
down to normal.
now it's 441. I mean, it's still on the higher end. Again, children, small LDL particles, 90 or below. It's very low.
Well, yeah, but children, we cannot compare ourselves with them though, unless they're
I
highly
mean,
obese,
they,
right?
they don't have atherosclerosis, they don't have heart attacks, so I want to preserve that.
Okay. So for that, I mean, I really would do everything that I said, probably do a lot more of those nutrients and stuff and see how you can correct that. Maybe it would work better.
Yeah.
We've been using.
Dr. Tano.
Yeah.
Oh, good.
Go ahead.
Oh, no. I just want to state a study there that the bigger driver of small dense LDL in relation to it being significant is the LDL particle number. So for
Right.
example, if you have a high small dense LDL and you have a normal LDL particle number, that small dense LDL really does not have that much clinical significance. So really the driver, and this is a study that I can send you, the driver of really oxidation is coming from the LDL particle number.
The particle size.
Number.
The particle number itself.
It's the overall traffic in the arteries.
Right.
Right. That's right.
Go
ahead, Dr. Hildebrandt.
Yeah, we've been using grapefruit seed extract, and we seem to have some pretty good success with that. Lowering total cholesterol, the LDL. I don't know about the particle sizes, but any experience with that?
You said grape seed extract? We can't hear you anymore, Doctor.
Yeah, you got them from Pamela Smith. She always says something like of that nature.
Yeah.
Pomegranate or grape seed.
And of course, he's not here. He's not on with us tonight. Our beloved Dr. Halassa and his cyclo.
So the grape seed extract is actually an aromatase inhibitor. You guys know that, right?
I didn't know that.
So the grape seed extract is an aromatase inhibitor. So how does that reduce your particle size? I'm not sure how that works. But if you have, let me just summarize. If you have too much estrogen, that makes your insulin go up.
Mm-hmm.
If your insulin is a catalyst for making cholesterol, then certainly reducing the estrogens may improve your cholesterol numbers.
If it doesn't,
so that's another way. So if you're blocking the aromatase and you're not converting testosterone to estrogen, maybe Stefan, that's something you can do. If you're blocking your testosterone from converting to estrogen, and you don't have a lot of estrogen in you, and you're not increasing your insulin, so if you don't have too much insulin, then you're not going to convert your HMG-CoA reductase. When I started off, I said the catalyst is insulin. If you don't have much of insulin around, then you're not going to make all this cholesterol down the hill. And if you're not making that, perhaps your particle size will be lower. That is something that I can see the connection.
Okay, but at our AMMG group, there's a whole cadre of folks who are against aromatase inhibitors, in any shape or form. And one of the claims is that that's a way to raise HDL cholesterol, is to raise
HDL or LDL?
HDL.
Okay. So why? I mean, I personally don't see that in patients. I don't see them increasing their cholesterol at all when we block their, we use aromatase inhibitors.
Yeah, we have knockdown, drag out fights, just about every meeting because of this. So, maybe I can get one of the proponents to come on and give his
And tell us, because I don't see it. I don't see why aromatase inhibitors will cause cholesterol problems. I really don't see that. And it would be important to look at the whole picture, though, in terms of the estrogen dominance and how that affects insulin and how that affects cholesterol, how that affects all the stuff that we see around.
One of the doctors there, the John Camarilla, his goals for males is a total testosterone of 2,000 and an estradiol of 150.
That I would not do that. I don't agree.
Not do that.
I would not do that.
I'm just reporting that what we've heard over the last couple of years, and
because when you get that, you can get polycythemia rubra vera. you can jack up all your hemoglobin to I don't know how much.
Yeah.
So take a look at my screen here. So I did a study for us all. I compared Vibrant to LabCorp at the same day. I drew this blood the same time in October 10th, 2024, to compare the two different type of lipid panels that these two companies do. So Vibrant, they won't do like a lipid particle count, but they will look at the small dense LDL. So they do this SD LDL particle, and it'll give me this number, and then LabCorp will give me a different number. So the Vibrant always put me like within range.
Correct.
So it made me happier to do Vibrant than LabCorp. LabCorp makes me unhappy. It gives me a lot of
And
red.
your LPA also is very low. It's less than 7 right here. Look at that.
Oh yeah, I've always been like that. It's good. It's lucky.
So somebody asked in the chat, how do you treat the LPA? And that's what I told you about niacin. So if you have high LPA, then you have to do high dose niacin to try to treat it. And that's the best treatment, by the way.
Right. And then having a homocysteine, my optimal reference range for homocysteine is like 3 to 8. And above that, I'm concerned that they have problems. What do you think?
Yeah, but homocysteine is, well, you can go a little higher than that. If it's like 8, 9, that's okay. But if you get to 11 and stuff like that, it's getting high.
You definitely have a problem.
Right.
Then triglycerides, I like to see triglycerides between 30 and maybe 80 tops, maybe 90. Above that, they have a problem with eating too much carbs.
Correct.
Right. And then for ApoB, I like to see it below 80 if possible. Now, my
That's what
ApoB
I
is
said. It has to be less than 80. So if you go over 80, and that's the result that I showed you, I give you the numbers and show that should be less than 80. So if you over that, then that's not good.
yeah, mine has been over 80 a couple times, so I've not always been happy with my ApoB, but this test was the first time I've gotten a score of 78 when I was taking the growth hormone level, the 3 units growth hormone. So take that for what you will. And besides that, my HDL has always been low. I try to improve my fish now, so we're going to see if next time it improves.
Right.
The myeloperoxidase is a cool test. You didn't touch on MPO too much. What do you think of that marker?
So the myoperoxidase, that could oxidize your LDL. So what is the range?
It's up to 600 is where they start saying there's a problem.
Yeah, I think 372, that should not be too bad, eh?
Yeah.
Right. Many patients will have high.
Yeah.
LPPLA represents plaque formation, and myeloperoxidase MPO is plaque rupture. So That's the difference.
Rupture.
One is a danger, and then one is one is at risk, and one is much more serious. The MPO, when that's high, myeloperoxidase, that's a plaque rupture. When that's high.
Right.
Yeah. Isn't myeloperoxidase also the body's way of producing hydrogen peroxide in an
Yeah,
attempt to
it does contribute to the oxidation too. Yes.
But is that also a sign that the body's trying to fight infection?
That I'm not sure.
That's my theory.
But that was
It's a sign of infection.
C-reactive
Can
protein.
someone speak about the homocysteine, low homocysteine, because I understand that's just as bad as high. What are the effects of low homocysteine? And I would think 4 is low.
Well, what's the problem with low?
I think there is a problem with it, but I can't speak to it. Can someone else chime in on that?
I'm not sure about the low homocysteine because I haven't seen any low homocysteine anyway. Most of it is in the range of 5, 6, 7, 8, at least for my patient. And so I never really cared to know unless if I know when it's high, it's a problem because it causes all the arterial problem that we have. But when it's a very low, it's just like creatinine to me. If the creatinine is low, does that mean they're having a kidney failure or something? No.
No. I use low creatinine as a marker of low muscle mass and low protein intake.
Right. Yep.
I saw a client who had low homocysteine, and she had a functional medicine doctor telling her to use cysteine.
To eat
when
cysteine?
It was low. To use cysteine.
Oh, interesting.
Never heard of that.
Could indicate, of course,
Yeah.
low B12
This is the first
and
I
folic
heard of
acid.
it, this particular person.
Very interesting.
Okay,
So,
thank you.
Yeah, very good.
Low homocysteine, malnutrition, malabsorption, overmethylation, poor detox capacity, methylation imbalance. Okay.
Yeah, so they have to do more methylation, like methylated cofactors.
Correct. Yeah.
I have partial mutation on folate. I have.
Yeah.
So Dr. Tano, just to add to the interventions for lipoprotein A, so hormone therapy, specifically estrogen, definitely helps lower down lipoprotein A, and this actually can give you at least around 20% decrease. And the studies actually showed that these were done with oral estrogens. And another one would be aspirin. So that's also another 20% that lowers down lipoprotein A. But the breakthrough in lowering down lipoprotein A there's now new drugs that are being made. These are the antisense oligonucleotides. So that's still going to be in the future. They're in trial phases now. I think it's palacarsen, or it's just a weird name, but they actually have claimed 90 to 95% reduction of lipoprotein A.
Interesting. That's cool.
Still experimental though.
Yeah. So every drug has side effects. We see what happens, right?
I know that we're the guinea pig for that.
Yeah, in terms of estrogen, though, many people are claiming estrogen as being the panacea for everything, like what Dr. Clearfield is saying. People say that if your estrogen level is 150, that's really great when you're doing hormone replacement. I say no. In this environment where we have so much estrogen, we have xenoestrogens as a major contender, including the glyphosate and all of those things that is in our food. Perhaps not a good idea to add too much estrogen, because any estrogen can cause problem. Many people see estradiol as benign, but estradiol is not, because the estradiol interconverts with estrone, and the estrone can go to the 16-alpha hydroxyestrone that is going to predispose people to cancer. So if you tell me I should increase my estradiol level, I would say no, I don't want that to happen because I could create more problem than it is worth.
As
If you have,
Dr. Halasa says, you want a 1-to-1 ratio of estrone to estradiol, which
right.
I was able to achieve here. So you can
most of the time, because the conversion they go both ways, so estrone can go to estradiol, but
Right.
the route to go from estradiol to estrone is bigger. So if you have tons of estradiol, you can make more estrone that way. And if you're doing that E1, if you're not lucky, it goes to the 16 alpha, and that is going to cause more problem than you want.
Right.
One question in the email, because
Yes.
you answered already the lipoprotein A question. Niacin, for it to work, I think this was asked a while ago. Do you need to flush, or it doesn't matter if you flush or not for you to get the cardiovascular benefit?
According to McCarran, the flash one is the more potent one. And for him, you do the flash, it will be painful for a couple of days and then it goes away the more you do it. So if you want to get better results, then you can stick to the flash one and it may be useful that way. But there's a non-flash that is available from other companies, and you can try that too, high dose.
All right, there's a product called inositol.
What do you think
Go
about
ahead.
progesterone? Progesterone to balance out the testosterone.
Yeah,
whole process.
I always give progesterone to men because
Okay.
the progesterone helps you make your testosterone, but also prevents the testosterone from going to DHT. So
Agree.
you're not making the dihydrotestosterone out of the progesterone and DHEA. So if I give you progesterone, DHEA, I put an aromatase inhibitor there, then you make your own testosterone. You make probably a little bit of estrogen, but it's not going to cause trouble, and you're not making DHT out of your testosterone.
Agree. Thank you.
Sure.
Okay.
So Dr. Tano, there's called inositol hexanicotinate that was before, and this is a non-flush form, and it was ran through studies that, yeah, it doesn't have the flushing effect. It also didn't get the results of altering the lipid levels. So
Correct.
that kind of supports that theory that the flush is
The flush
probably
one is
needed for
better.
you to get that cardiovascular benefit.
Yeah, the flash one, so many people think the flash one works better, but some people don't like the side effects of it. Like I said, they said if you can stand it for a few days, then you can do better with it.
No, I felt really bad taking it. I had to stop. Chest
Yeah.
pain.
Yeah. So you have to hang in there. You have to be tough.
I
You know,
would
I don't
eat
know if you
red
have
potato.
Scientologists in your practice. They have a process to cleanse themselves of using high dose niacin for a few days consecutively. Because I
Right.
have patients who are Scientologists, and this is very interesting that this is a process in their I don't know, culture, is that what you call it? But
Right.
it's, yeah, they bump it up in the niacin dosage like really high.
It's religion. It's not culture. It's religion.
They
Yeah,
get
I
this.
guess. So
They get an out of body experience with the doses, and I've experienced
yeah.
that. You feel like you're floating away. It's crazy.
Wow.
Yeah,
Wow.
it's not good. I don't like it.
Just, I always take the I take the non-flash one because I never really want to experience anything bad. So
Okay. Dr. Nario, you got any questions from
I already asked it. So majority of them were asked when you were reading the chat.
Okay, Doctor.
Good.
Any takeaways?
yeah. So who did you see, Dr. Quinn or me? Takeaway is that you always have to do your lipoprotein fractionation test, making sure that you know how to interpret it, and making sure that your patients are covered with some sort of blocker if they have particle sizes that are abnormal. Don't ignore the particle sizes because they can get into trouble that way. So it will be very important for all of us to check the, and also advise the primary care physician that we know, or educate our patients who go through a primary care physician to get the cholesterol test, to do the lipoprotein fractionation test, because this test has been around for years and we cannot wait and 25, 30 years later, people still not doing it. It's important to do that before we put people on statin drugs and cause trouble for we kill the manhood. Because if you're reducing the LDL cholesterol that is used to make our testosterone and making all these other stuff, then many people are not going to do so. And many of the old folks who are all on statin drugs, maybe that's why they're not doing so well. That's why they're frail, they cannot build muscle, they cannot do that because they're reducing their livelihood. And we should probably go against that.
Yeah, one last question.
Dr. Quinn, you're muted.
Hang on. Thank you, Dr. Tano, for everything. And we got 2 CME credits here.